Hi, my name is Stephen Poplack. I'm a professor of radiology and a breast imaging specialist at Stanford University. So the question is, what are the different types of breast biopsies? That's a great question, and it can get a little confusing. So let's start off with the broad categories of breast biopsy. You can have a surgical biopsy, or you can have a needle biopsy. A surgical biopsy means that that tissue, the abnormal tissue in the breast, is removed surgically. Typically, that's done on the same day surgery. It's a very short procedure, not a risky procedure. It's usually done with local anesthetic and with some intravenous sedation medication to relax the patient while they're having surgery. And usually there's a very quick recovery. That is often reserved for palpable or feelable abnormalities in the breast because that lump in the breast bothers the patient, whether it's benign or cancer, so it makes sense to remove it. So that's the first big category, which is surgical biopsy or excisional biopsy. The next big category is needle biopsy. And we can break a needle biopsy category further down into image-guided, that's using an imaging modality to guide us to the right spot, or palpation-guided, so something that's feelable, and we guide the biopsy based on what we're feeling. The minority is the palpation-guided, and that's typically with a very noticeable breast lump done by the surgeon in their surgical clinic or their surgical office. The majority of breast biopsies now are done with image guidance, and it's been actually relatively recently. We didn't have image-guided biopsy till the 80s, and we didn't have what we call stereotactic or mammography-guided biopsy until the 90s, and MR biopsy until late 90s, 2000s. So relatively recent advance in medicine. There's a common set of conditions for each of those image-guided biopsies. The first thing we do is we're going to confirm the abnormality or our target based on the imaging that we're doing. You're going to be positioned based on the type of image guidance that you're having. And we're going to clean off the breast with antiseptic solution to make sure that we prevent infection related to the biopsy. So we clean off the breast, we numb the breast very thoroughly with a local anesthetic. We make a small incision in the breast, a little nick in the breast, and then we guide the biopsy needle to the target, to the abnormal part of the breast, using that imaging modality. We then take samples, which we will later send to the pathology department for them to look at the samples under the microscope and make a diagnosis. And after we've taken the samples, we put a marker in the breast to mark that spot. A lot of patients wonder why we bother with the marker. And the marker is very important for two reasons. First, most breast biopsies are benign, and we want to know for future communications in this modern world where patients go from one facility to another. We want to leave a record that a biopsy has been done at that site. Rarely there may be a little bit of scarring related to the biopsy that may look abnormal, but if we have a biopsy marker there, we know it's related to a biopsy and don't have to be concerned about it. So that's on the benign end. On the cancer end, if the biopsy turns out to be cancer, it's important to have the marker to find that area clearly in the future when we go to localize that area for surgery. And also when that tissue is removed, to prove that that area is included in the specimen. So very important to have a biopsy marker regardless of the result. Let me talk a little bit more about the individual types of biopsies. So let's start off with ultrasound guided biopsy. That is usually the most comfortable for patients. If you've ever had a breast ultrasound, you lie on your back. Often we have you rolled up a little bit on your side onto one hip, with your arm placed up over your head, raised over your head. We first do the ultrasound, confirm where the abnormality is, then we clean off the breast, numb the breast, and when we do the numbing and when we do any part of the procedure under ultrasound, we're actually watching with the ultrasound transducer, that's that plastic piece that's on the breast. We're watching as with one hand as we're doing the procedure with the other. So we can actually see in real time exactly what we're doing during the biopsy. So using ultrasound, we'll watch as we guide first the numbing needle to the right spot, numb the area very thoroughly, and then watch as we actually take the biopsies. And again, we can see that in real time. We'll take the samples and send those to pathology and then place the marker. And then usually after that, we will do a mammogram to demonstrate where that marker is. Very rarely, we may think that an abnormality on the mammogram matches the abnormality on the ultrasound, and we'll do the ultrasound biopsy because it's an easier exam for the patient, and then come to find out when we place the marker that they're really two different things. That happens very rarely, fortunately, but that's another reason to do the mammogram after the ultrasound guided biopsy. So that's ultrasound biopsy. The next is mammography guided biopsy. You may have heard the term stereotactic biopsy. That stereotaxis, excuse me, is a pair of images at a specified angle. And when we have that pair of images, we can use that imaging pair to identify the depth of the abnormality. We also might use breast tomosynthesis, which gives us a slice by slice data for the breast, and we can pick the appropriate slice, which is the depth. So for a mammography guided biopsy, this time you're either lying on your belly on a dedicated biopsy table, or you're sitting up in a chair. Your breast is placed in compression. The plastic compression paddle has a little opening, and that's the area that we work within. So the technologist will position you so that the abnormality is within that open part of the paddle. We'll clean off the breast. We'll do imaging to identify and target the abnormality, numb the breast, guide the needle to the right spot. Now, we can't see that in real time like we could with ultrasound. So for that, we need to place the needle and then take another set of images to confirm that the needle's in the right place before we take the biopsy. So that's an extra step we do with mammography guided biopsy. We then do our biopsies, take the samples out, send them to pathology, and place a marker. So that's the mammography guided biopsy. The last biopsy is an MRI guided biopsy. This, you're lying face down for your breast MRI. Anyone who's having a breast MRI biopsy will have already had a breast MRI. So that's the same position that you were in for the breast MRI. The only difference is now we put the breast in mild compression in a plastic grid device, which helps localize the area. So MRI, we find abnormalities based on the way they take up intravenous contrast. So you'll be given an IV. We'll do imaging before you get the contrast. Then we'll give the injection and then do more imaging again to identify the abnormality. We use the grid there's a little GPS device on the grid that allows us to identify once we've targeted the area based on our workstation, on our console, then we know where their target is relative to that GPS system in the grid. So we'll pick the right area in the grid, we'll numb the breast, we'll place a little plastic, what we call obturator or placeholder, then put you back inside the bore of the magnet, repeat imaging to confirm that we're exactly where we need to be to do the biopsy, take you back out of the magnet, do the biopsy, then go back in, scan again to be sure that the area of abnormality has been well sampled. Then we'll place a marker, and ultimately we will do again a mammogram to show where that marker is in the breast on mammography. So those are the three different types of biopsies for image guidance. There are some differences in the needles that we use. With ultrasound, you have a choice of using a spring-loaded needle, which is a little smaller needle activated on a spring that takes little pieces of tissue, and typically will take somewhere between 3 and 8 samples. Or you could use a vacuum-assisted device where there's actually suction attached to the biopsy. Tissue is drawn into the biopsy chamber and then snipped, and then we call that a vacuum-assisted biopsy. And that can be used for ultrasound, typically used for mammography and MRI. So we don't use spring-loaded needles for mammography or MRI biopsy. Lastly, a question that often comes out when I speak with patients before having their biopsy, or when I'm talking with them and recommending a biopsy in our diagnostic clinic, and they'll say, ask me, why don't we just take this out? Why don't we just remove it? And that's really a very great, excellent question. And it's not intuitive why you wouldn't remove it. But the answer is, first of all, that most abnormalities, upwards of 75%, are not going to be cancer when we do the biopsy and don't need to be removed. The biopsy procedure is typically very well tolerated. Once the numbing is in, you typically don't have pain with the biopsy. It's not risky. There's very, very low rate of having a complication, and those, less than 1 out of 1,000 chance of causing bleeding or causing an infection. And usually the next morning after the biopsy, you're pretty much back to normal, very minimal activity restrictions. So it's a very well tolerated procedure. So if you have a benign abnormality that doesn't really need to be removed surgically, why not have that easier, quicker type of procedure? So that's on the benign end. On the cancer end, if we do diagnose cancer, it's very important to know that up front before you have your treatment for the breast cancer. So it allows you to have a discussion with your surgeon and the care team about what type of surgery you want to have. Do you want to have a mastectomy with reconstruction, so remove the breast and kind of rebuild the breast with either an implant or with your own body tissue, like a tissue flap from your belly? Or do you want to have a lumpectomy? And if you're going to have a lumpectomy, so only a part of the breast is removed, it's important to know it's cancer, because the surgeon's going to take a little bit more tissue to make sure that there's a margin or rim of tissue around the cancer that's free of cancer. And that lowers the risk of the cancer coming back in the breast. And also nowadays, for patients who have more advanced breast cancer, it's important to know that you have cancer up front, because you may be treated with medical therapy before you have your surgery. So you may be treated with chemotherapy or endocrine therapy before you have your surgical treatment. So really, really important to do the biopsy, know what we're dealing with, so we can make informed decisions about how to best manage the problem.